shines on the hammer, light shines on the moon, treason in the heart and fire. Oh, standing by the doorway, the night is getting warm. The wind blows by the window, as the music is getting low. It's you really doesn't mind to love to find, love to find you, love to find. Solitude in my bed, love ain't got no lines, companion in my heart, love a sacrifice, ain't got nowhere to go, but things you left around me.
Hello, my friends.
Hello.
Are you available? Are you ready for the next episode? See you soon. Amori,
Kato.
Amori.
Hello. How are you?
Hello.
Can you please explain to me in a way that I understand why you want always to start 3 minutes to 8 and not 8? 3 minutes to 7 and not 7?
No. Look. What time is it now? 7. Perfectly 7. So it means that we are on time. We are not 1 minute before, one minute later. Hello, guys. I like very much this comment. Ready to rock and roll from here in England. Yes. Yes. So,
Not only England, of course, but also Romania, France, Italy, Turkey, Ukraine, Germany, Uzbekistan,
Yes.
Hungary, UK. Did I say UK? I don't remember.
Garda Lake. Garda Lake.
Garda Lake.
Where's Garda Lake?
In the north of Italy. It's a beautiful place. Beautiful. Lago di Garda. How did you spend your week, my friends? Everything okay?
Enjoying life.
Enjoying life. Beautiful, 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 beautiful. What are we talking about today?
By the way, we have a nice representation also of Latin America, Argentina, Brazil, Colombia.
Great. Yeah, you see, Sebi is very reactive. Question of the week. Do you perform nail surgery yourself? Yes, no, sometimes. Nail surgery is something disgusting. You know what?
I hate it. I never do it.
It's
I hate it.
it's really disgusting. But there are dermatologists who likes a lot. Yeah.
Let me tell you, it's much easier than what you think.
Yeah. Nah, come on. Yeah, to cut these fingers. I mean, horrible.
And too much blood. Like, I hate
A
it.
lot of blood.
Yeah.
Well, majority, 77%, of course, say no. But, 13 say yes, and 13 say sometimes. Good. Perfect. Perfect. So, guess what? We are talking about nails. Huh? Did you prepare something for us, Emilio? Seppi, are you ready?
But Sebastiano, did you remember to prepare the poll for the quote of last week?
Because I do from this episode, not
No, Sebbi, you had to prepare the poll of the last episode with all the quotes that were coming out from the episode.
Yes, but now since this is not possible at this moment, maybe because I don't want that we miss a quote. So then maybe we select. I remember clearly that we were prone to select the dark side of the mole.
Dark side of the mall.
Dark side of the mole.
Dark side of the mole.
Yes.
Like it.
I love it. I love it. There is
It was the best.
Yeah, of course, from which team is coming this citation.
Which
No.
The Dark Side of the Moon, Pink Floyd.
Oh, yeah.
Yeah. Okay.
You are young guys.
No.
No,
We understood the
I was
reference.
thinking about the department.
Yeah, I also thought departments, like which department
Yeah.
is the dark
I
side
was
of
just
the
thinking same minds.
Okay. So the Dark Side of the Mole. Bene, Seppi, do we need a jingle for the paper or no? No, maybe not.
Well, why not?
Well, yeah. Okay. Emilio, what you prepared for us?
Wonderful. So I prepared for you
Yeah.
very nice paper that we will see shortly.
Uh-huh.
Before this, we take a look at our list. I just completed the last one. Yeah. So please remember during the episode to propose quotes for today that we are going to vote during the Kahoot. Huh? Do you like our list?
I like it very much.
It's a nice. Well, of course, Tina for president is maybe my favorite.
Definitely. It's among the winners. Yeah. But look for the folly clues is also nice.
Folly clues is also nice. Yeah.
I think that don't rush on the Ras is my favorite.
All of them are nice, but I don't know. I don't know why, but I have a strong preference for Tina for president. Wonderful. So our paper for today does not come from dermatology practical and conceptual.
Really?
Yes.
Why?
Well, because it was tough, let me tell you, to find the paper on the topic that I wanted to I wanted to speak about. And I found this nice one, which, by the way, it's by an Australian group that is quite recent. You know, the many well-known names, friends and colleagues from Australia. They did quite recently a systematic review of the literature on published evidence about the dermatoscopic features of inflammatory nail disorders. We don't have so much, at least in terms of evidence. We have some, we have several case reports. We have our own opinion about how the one and the other thing might look, but in terms of evidence, we don't have much. In fact, this is what we have. So you can see that not many entities have been described adequately in terms of the dermatoscopic patterns on the nails. So we have trachyonychia. I will show you an example. Nail psoriasis and lichen planus. For these two diseases, we have some clues. For example, for psoriasis, we know that pitting is very important, and brittle nails and these deep transverse grooves. And of course, in the peripheral part, we have distal onycholysis and splinter hemorrhages. This is also an important clue for the diagnosis of psoriasis. In nail lichen planus, rough and brittle nails, pitting again, red color, red lunula, but also sometimes the red color quite evident in the nail bed. Additional other features also. Onychotillomania, nail lichen striatus, just one paper about allergic contact dermatitis due to artificial nails, which, by the way, is quite frequent, I have to say, in clinical practice, but we don't have much evidence on how it looks like. And of course, there are some studies about onychomycosis, onycholysis, and very few for less frequent entities. Of course, there are clues for tumors, but this is not the topic of this paper. So let's see 3, 4, 5 examples from this paper that highlight the main features of these frequent entities, starting with trachyonychia, which usually is idiopathic, but sometimes it is a final result of the nail changes in the course of another inflammatory disorders, but the majority of cases are idiopathic. And we can see this typical sandpaper-like surface of the nail clinically. That's very, very well known. And we see dermatoscopically that, first of all, there is involvement of more than 50% of the proximal nail plate. Well, in general, almost the entire nail plate is affected in trachyonychia. And we also have this longitudinal ridging that is highlighted here by the white arrows. That's very, very frequent in this entity in trachyonychia. Then the next that I would like to show you is an example from this paper of nail psoriasis. We can see the pitting, but I will show you in a moment an even better photograph of pitting, and also the splinter hemorrhages, and of course the distal onycholysis in the peripheral part of the nail plate. I think that these photos are better. Already from the clinical point from the clinical aspects, you can see a typical pitting, and also this green. In the last year, in the books, it's written as oil drop, something like this. This green thing on the nail. And dermatoscopically, it's much, much more evident that this is the nail pitting, and this is the green, yellowish to green, typical oil drop of nail psoriasis. Then, in lichen planus, here we have another typical finding, which is the so-called onychorixis. I like very much these words because they are all Greek. So we yeah, we can understand them well, but I guess that this is not so easy. Onychorixis, and of course distal nails splitting again. And look, this red color on the background, the red color of the nail bed is very, very frequent in lichen planus. Of course, in lichen planus, there is another feature of the nails, which is very, very typical when present. Of course, I'm speaking about this. This is an initial version of the so-called pterygium, and this is another, maybe a better image of the fully developed pterygium that is a typical sign of lichen planus. And of course, with dermoscopy, it's highlighted even more. Then onychotillomania. Onychotillomania, similarly to trichotillomania, is featureful. Also, if you remember, in trichotillomania, we see many types of hair deformities, of the hair shaft deformities, because of the continuous trauma. The same thing also here, because of the continuous trauma, we see quite a lot of things, including blood, of course, hemorrhage, but also loss of the nail plate, reasonable because of the continuous trauma, and also these wavy lines that result from the fact that the nail plate growth is interrupted because of the trauma, and this results to these wavy lines. And another photograph from the same paper, interesting because I've never seen a dermatoscopic image of this entity, so I didn't even know that there was a description dermatoscopically of nail lichen striatus. And we can see dermatoscopically this fissuring of the nail plate and also some white papules on the skin. That's what this paper suggests as typical of nail lichen striatus. And finally, onychomycosis. This is a case of quite advanced onychomycosis with significant subungual hyperkeratosis, and dermatoscopically we can see the yellowish discoloration of the nail plate, especially in the distal, in the peripheral part, in the 2/3 of the peripheral part, and also white, yellow streaks, and of course subungual hyperkeratosis. I would like just to finish with another case of onychomycosis, much more early, which is not rare, by the way. We have associated green color on the nails with two things. One is psoriasis, already discussed. Second is Pseudomonas. We always associate green color with Pseudomonas, but quite frequently trichophytic infection of the nail might be pigmented, and this is a case of Trichophyton rubrum. You can see also the free-edge dermoscopy helps a lot because you can see that the pigmentation is really in the nail plate, and there is also subungual hyperkeratosis. So that's a case of trichophytic infection from Trichophyton rubrum, but it's somehow pigmented in the sense that we see this green coloration. And that was it, my friends. I was faster than usually. Yeah?
Beautiful.
So we have time to see several cases that you have prepared, and I also have some more if needed. So that's it for the introduction.
Yes, let's say nails are interesting anyhow, even though it's very often quite, don't you think that it's a frustrating area of our professional life? Because I mean, of course, from a diagnostic point of view, very often we are able to get to the right point, but then therapeutically, it's not so easy, right?
Yeah, but also diagnostically, I mean, it's just, in my view, in the recent years that we became able to understand, to recognize different entities. Also, these benign tumors of the nail plate that are very, very frequent, but like onychopapilloma, onychomatrichoma, and so on, the patterns were quite recently described. So from a diagnostic point of view, it's not, I don't think that our knowledge is very, very advanced. We have much more to learn and to study. And as you say, from a management point of view, then it's even more tricky.
Yes. There is a question from Doriana. Could you expect to find a singular linear brown and central pigmentation in association to fungal infection as a result of melanocytic activation?
Yeah, that might happen. That might happen, especially in dark skin type individuals. That might happen.
Yeah. Yeah. Maybe I just share with you the one case that I prepared. One case. One.
Before you do that, JP, just one comment. I think that the most difficult part about managing patients with nail conditions is convincing them that they don't have onychomycosis.
Yes.
Overdiagnosed
Yeah.
condition ever.
This is typical. This is typical. Everything happening on the nails is onychomycosis.
Doesn't it happen to you often that the patients come with the diagnosis given? So they say that I came for my onychomycosis.
Or I came because I have onychomycosis, but I treated and I didn't solve it.
Exactly.
I've been putting Lamisil or whatever for 1.5 years and it doesn't go away. Well, yeah.
Yeah. No,
Another
I
question.
just prepared one case, which is actually two cases. And the funny thing is that this is also often happening, in my view, also to you guys. When you see something peculiar, you see a couple of patients having the same peculiar stuff, right? In a sequence. And these two guys, these two patients came quite in the same period. I would say that they are both showing more or less the same clinical features. Both are, let's say, adult patients, men. Both are, there is a pathology located on the first finger of the hand. It's looking linear in both cases. In my view, what is attracting my eye is the nail destruction. Yeah, the nail dystrophy. But let's speak about destruction. So it's a kind of thing which is, let's say, provoking a kind of destruction of the nail. Let's see if dermoscopy is giving us some more clues. On the right, I see that probably there is something going on in the nail bed, in the central part of the nail bed, because the nail destruction is mainly distal, while on the left side, the nail destruction is quite more advanced. So it's involving the entire longitudinal portion of the nail. Let's do so. It's very difficult. Let's do so that one is a word and another one is an SCC. Now you have to tell me which one is the word and which one is the SCC, squamous cell carcinoma.
I would have said that both are HPV-related SCCs. So
Yeah.
I lose. Well, I will go with, because it's you, I will say that the right one, the less conspicuous, is the SCC, and the left one is the...
Yeah. So also from this, also knowing, in my view, also knowing that one is a word, we still can be wrong, because we could think that maybe the less involved nail is affected just by a word, but it's the opposite. It looks like the left side is a word. Both cases, of course, were histopathologically biopsied for histopathologic examination. Yeah, and that, so right side SCC, as you said, Costas, usually a squamous cell carcinoma on the face, on the body is related to the sun-damaged skin, but there are areas in which squamous cell carcinoma is related to HPV, of course, genital penile squamous cell, and vulvar squamous cell carcinomas are related to HPV, but as you correctly said, also nail squamous cell carcinoma is related often to HPV. And you have an explanation for this?
But what?
About the squamous cell carcinoma of the fingers is related to HPV. Yeah. Anyway, we don't know.
No, HPV is anyhow very frequent. And
very frequent. I mean, you have
common words
everywhere, and fingers are let's say, the most exposed to environmental factors. Yeah, yeah. So this is just reminding me that squamous cell carcinoma, it's even more difficult to diagnose than melanoma when we are speaking about nails. Okay, so it's extremely difficult. It's obviously mimicking something else very often, like a wart, like a pyogenic granuloma, even an onychomycosis sometimes. So we have to make sure that we keep in mind that an adult patient with a solitary lesion looking like a wart around the nail, I mean, we have to think about SCC when, of course, for example, there are problems in treating it, when there is, so this wart is relapsing many times after proper treatment and so on. So this was just... Yeah.
Maybe clue is that squamous cell carcinoma eventually will destroy the nail plate, and of course it will do it slowly. It will start destroying a small part of the nail plate and then continue. So obviously that's an alarming sign when we see a destruction of the nail plate. It should not happen reasonably in the course of a benign tumor. But the wart you showed just now also destroyed the nail plate. Yeah, okay. So that's
probably, I don't know the history about this patient, but probably this was a very long-standing problem, and they were also maybe who knows if he got previous surgery for removing this wart. We don't know.
Yeah, there is a way, by the way, the question, by the way, that you practically answered, if there is any good way to distinguish between early subungual wart and squamous cell. We discussed about it right now.
Of course, there are a few. Also, dermoscopy can help, and in wart we expect to find splinter hemorrhages. This is the most obvious clue telling us that the difference between a wart, which is showing splinter hemorrhages, versus squamous cell carcinoma, which is usually not showing this kind of clue.
But you know that I have a problem with defining this HPV-related squamous cell carcinoma. So of course I cannot prove it, but I have the opinion that many of these squamous cell carcinomas diagnosed as squamous cell carcinomas, but in fact are located to HPV-prone locations like genitalia or nails or finger. In fact, they are not squamous cell carcinomas. It's just, I mean, HPV infection that at some point, I mean, okay, the cells acquire some atypia, but it's, I mean, a very low grade condition in terms of malignant potential.
At the beginning is low grade, but of course,
but for a long period.
Yes, after a while, it's acquiring anyhow an aggressive potential. We know very well that squamous cell carcinoma of the penis could be very aggressive. So
He asks a very interesting question, to which I don't have an answer. I don't know if you do. Whether HPV vaccination can protect us against nail SCC.
Well, theoretically
it should.
Yes, theoretically, yes. Nowadays, I'm very happy that when my daughter was a teenager, the HPV vaccination was only permitted for teenagers who did not have sexual intercourses.
Mm-hmm.
Nowadays, everybody can do it. Of course, I didn't understand why this was a prerequisite at the time. But in my view, it's nice. Everybody should get it. I mean,
it's wonderful. Do you have any age restrictions in Italy, or can anyone get it?
Not anymore. Not anymore.
Yeah. For us, it was up till the age of 17, I think, up to 2 years ago, and now it has risen to the age of 26.
Okay.
But still, there are restrictions.
Yeah.
In the States, Joanna says it's from 9 to 45. Another question was earlier about aspergillosis and candidiasis. What about, well, aspergillosis? I don't know if there are any dermatoscopic clues to discriminate aspergillosis from fungal infections like trichophyton. I think, to my knowledge, it's just a result of the lab. Concerning candidiasis, yes, candidiasis should have a different clinical, first of all, pattern. Candidiasis typically begins with a perionychia,
Yes.
and later on.
Yes, candidiasis is definitely something which
And
involves primarily the periungual skin.
I was wondering, where is our friend?
Hello.
And then another question, which is the best treatment for nail lichen planus in multiple fingernails in a patient with chronic hepatitis infection?
Topical steroids.
Yeah. Topical steroids, first line.
So practically,
Topical steroids, the end. Punto.
steroids is like saying we don't have an answer. Steroids, yeah, come on.
Lichen planus remained lately quite an orphan disease from a therapeutical point of view, because nowadays we can treat psoriasis and dermatitis with many additional new drugs.
There is always cyclosporine, of course.
Yes, of course. Yeah.
But the patient has hepatitis B or C.
See,
C.
Sebastiano is trying to show something. Oh, bravo, Sebastiano.
Bravo, Sebastiano. Bravo.
Beauty comes in multiple forms. Our imperfections are what make us unique. The Aven Dermatological Laboratories are by your side to give you the confidence of a healthy, glowing skin, thanks to its products that soothe, protect, and repair. Otermal Aven, the confidence of healthy skin.
Wonderful. Allora, guys, Nisa, did you prepare something for us?
Nisa, you are muted. You are muted. Unmute yourself. Nisa, unmute yourself. Okay.
Yeah. Is it okay?
Yes.
Okay.
Oh, there is, by the way, an important question to answer. In case we suspect an SCC, which part of the nail lesion is better to take a biopsy? This is important because this makes a big difference between melanoma and SCC. In melanoma, as a rule, we have to biopsy the nail matrix. In SCC, SCC generally starts from the nail bed or the periungual skin. So we have to choose the part of the lesion which we think it's the worst part, you know? So there is no rule. We just have to decide which part is more representative clinically, and then we choose this one.
Yeah. So in my view, the treatment of squamous cell carcinoma of the nail requires that we remove the nail plate, the entire nail plate, and also we reveal the matrix so that we understand where the tumor is located, and we treat it in the same way that we treat a skin tumor. So we excise what we see, what we consider as tumor. It could involve just the bed. It could involve both the bed and the matrix. So whatever we see, we excise it. Unlike melanoma, in which to deal at all with the nail bed, everything is always in the matrix. So it's. There is another question about Barrier disease from Doriana. If dermoscopy can help, I have no idea. I don't know if guys, you have any.
No idea.
I'm gonna show you. I'm gonna show you in this presentation some pieces
nice.
of Doriana.
Okay, go, Nisa, go.
Okay, guys, there are cases, and what do you think it is? They have the same diagnosis, the superior and the inferior one.
Nisa,
And this is also.
Nisa, we
Can you see?
only
Can you
your
see my?
No, we see
sorry.
only one photograph. We see only one clinical photograph of one nail.
Just click. Oh, really?
Yeah. So maybe you
So
escape and you put it again.
you don't. You don't see it?
We only see one picture of
One picture.
thumb
Yeah.
Which
Can I
camera?
share again my
Yes.
screen?
Yes, try
Yeah.
again.
Stop sharing and do it again. Okay. Okay.
Is it okay right now?
Yes, yes,
Again,
yes.
play?
Now it is
Okay.
okay.
We see
Uh,
three images, probably two
yeah,
cases.
we have two cases here, and they have the same diagnosis. And this is the macro images and dermatoscopy and subangle part, and this is also the same diagnosis. So what do you think it is?
Dermatophyte onychomycosis, non-dermatophyte onychomycosis, Pseudomonas, Bowen, and candidiasis. I vote for candidiasis.
Okay, I'll second Jeppy.
Is the poll launched?
Yes.
Okay.
Let's
So we
see.
have the winner is onychomycosis, dermatophyte onychomycosis.
Yeah. Okay.
And followed by candidiasis, which would be also my
Yeah.
choice, onychomycosis. But anyhow.
Yeah.
Okay.
So let's go to the next slide. Now,
A
do
lot
you
of
change your
green.
mind? The pictures are from Northern Lights, and the pattern is a metaphoric terminology, but observed in this fungal infection. This is fusarium. We have mottled pigmentation, yellow, white, sometimes brownish color. And in metaphoric terminology, this is called as aurora borealis or northern lights. And this is so characteristic for fusarium. And this is also interesting. You can see an onycholysis and transverse over curvature of the nail. And sometimes there's paronychia around the nail. But when you see mottled pigmentation, this is most likely and non-dermatophyte onychomycosis and fusarium.
Wonderful.
So let's
Before
have a look at.
we move on, there is a question that I also wanted to do.
Mhm.
What about treatment-wise? Does it differ, the treatment for...
Yeah, the terbinafine is not effective in fusarium, and we should choose itraconazole or fluconazole. It is part of fungal infections, and treatment duration is generally 3 months, like the nail fingers of dermatophyte infections.
Yeah.
So this is another case. And this is a dermatophyte infection. We can see these longitudinal bands, which is very characteristic for dermatophyte infection. And there is a pigmentation here. This is a Trichophyton rubrum dermatophyte infection. And it's sometimes it can produce melanin pigmentation due to Trichophyton rubrum. And Aspergillus niger also produce this type of melanin pigmentation as well. But these strikes are very characteristic for dermatophyte infection. And you can see the pigmentation. This is very easy. We see yellow color. So this is Pseudomonas infection.
Yeah.
And this is Aspergillus.
Aspergillus, yeah.
This is Aspergillus. Yeah. You can see the dermatoscopy here. It's not very, very specific, I think, as Emilios told. So this here culture is the way of diagnosis for Aspergillus niger. And do you think for this one? Again, we have a pigmentation. This is a subangle dermatoscopy.
Go back to the image.
You can go back.
You cannot go back now.
Can you see?
Yeah.
You wanted to check if it's a pigmented onychomatricoma. That's why you want.
Yeah.
I think this is quite challenging because the subangle part is looking like onychomatricoma, but the surface looks like onychopapilloma, right?
Yes.
Then what was it?
Because we have longitudinal erythronychia starting from the distal lunula here. You can see a teardrop shape here, and this erythronychia, and there's pigmentation. And we made a biopsy here, and it was onychopapilloma, not onychomatricoma. The distal part, we can see some holes that we observe in onychomatricoma, but this was a case of onychopapilloma.
Beautiful case.
Wonderful.
Yeah. And this is very challenging. This is a 27-year-old male, and this is a baseline, and this is 9 months later. What do you think it is? You can see there is onycholysis in the second part, and in the first image, there's again onycholysis, but the shape is completely different.
Mm.
And this is a dermatoscopy.
Psoriasis.
Baseline and 9 months later.
But this
Psoriasis.
is
We have just
after surgery or spontaneously happened.
no surgery, no surgery. At the first visit, we recommend a biopsy for this lesion, and the patient didn't accept it. And he came 9 months later, and this time it was looking like this. There was a lot of vascularization around the periangle skin. You can see the vessels. The only clinical clue here was pain.
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 Mm.
Pain. It was a painful lesion.
Then, yeah. Then how old is the patient?
He's young, 27-year-old.
27. Okay.
Of the
Yeah.
ones you show here, one is painful, but
Yeah. It doesn't look like it.
it doesn't look
Yeah.
like.
Yeah, it doesn't look like for me as well. So I think in these type of lesions, really clinical palpation is very important. Pain is a very important symptom for gliomas tumor, and since it was painful, we recommend MR examination to the lesion, and you can see the glomus body here. And the lesion was excised, and it was really a gliomas tumor. But clinically and dermatoscopically, it doesn't look like a gliomas tumor. Just the pain was a clue here.
Yeah.
And we know gliomas tumor just look like
Yes.
the cases.
Yes.
Yeah.
That's the usual.
And I will be quick in this case, and this is a squamous cell carcinoma of the nail, and it really looks like a dermatophyte infection here. We have subangular hyperkeratosis, yellow coloration, but it was a long-standing lesion and didn't respond to antifungal therapy, and we performed a biopsy, and it was a squamous cell carcinoma of the nail.
Yeah. So, for example, here, Nisa, if you remember, if you can recall, which was the extension of the tumor. So it was, if you go back to the image, it was only the peripheral part of the nail bed that we can see hyperkeratotic, or also it was reaching the matrix area, because also in the matrix area we see some.
It wasn't in the matrix, just in the nail bed.
Only the nail.
Emilios. Yeah, nail bed, not in the matrix.
Yeah.
So as Jeppy told us, the main differentiation between a wart and a squamous cell carcinoma is the hemorrhage, pinpoint vessels, which is also called Auspitz sign. You can understand easily that the second one is the wart, and the first one is the carcinoma cuniculatum. It was an SCC of the nail. There's no pinpoint vessels in the first image.
Mm-hmm.
Yeah.
And there was a question. Have you ever seen a psoriasis of the nails, dermatoscopy? How is it specific? And here is a child, and you can see the pustules involving all the nails.
Yeah.
And here's the dermatoscopy, and it's very interesting. You can see the dotted vessels of psoriasis in the nail as well. And we treated the patient with infliximab. And this is 2 months after the therapy. It was responding well. And the first, I think 6 months later, I learned from my residents that the lesions all disappear, and the child was well after infliximab therapy. But I don't have the photos in 6 months. And these are the first group of photos are from a patient who has Derriere disease, you can see that longitudinal erythronychia is a very common feature, and sometimes we can see splitting in the distal part, but we don't have here. Just multiple erythronychia involving almost all the nails of the patient. And this is a lichen planus. You can see the pterygium here and longitudinal erythronychia. And this was a solitary lesion, just one nail. But the patient was diagnosed with lichen planus here with the biopsy. She was a young patient, but pterygium is very typical here. So this was my last case. Thank you.
Beautiful.
Very nice case. Wonderful, wonderful. How to treat aspergillus? There is a question: how to treat aspergillus? Itraconazole.
Itraconazole.
Itraconazole again, yeah. In that patient, we performed the nail biopsy because it was very. We can go back to the case.
We have to. Well, we have to remind that this kind of non-dermatophyte onychomycosis are, let's say, these are non-pathogenous fungi. So Aspergillus, Fusarium. So there must be always something in the background, either suppression or anything
sometimes
else.
tumors as well, especially for Fusarium cases. I think nail biopsy is very important in these cases, and you can take a fungal culture during biopsy. And in this patient, we removed the nail plate and sent it for fungal culture as well. But histopathologically, there was also some fungus in the histopathologic sections, and culture also revealed the Aspergillus niger, and we published this case. So it's rare, but I think removal of the nail plate should be done in these patients.
For the child with the psoriasis and the pustules, did you perform a biopsy, or did you have psoriasis elsewhere as well?
This was a very typical case of acrodermatitis continua of Halopu. You can see it was just involving the nails, and there were all pustules. And this was a clinical diagnosis here. We don't need to take a biopsy because you can see all the pustules involving the nails. So
Nice.
it's a clinical diagnosis, yeah.
Excellent.
Wonderful, wonderful. This poor child.
I want to say two things. One is that, guys, the quote, we have no proposals for the quote of the day. Then the
No, we have some.
Dying.
We have some. Wait.
Really? Sorry, I didn't.
Yes, I saw them before. If the nail is tricky, remove it quickly. Nice.
Yeah.
And the other one, let us nail it. Also very nice.
Let us nail it. If the nail is tricky, remove it quickly. Okay, please send additional proposals that we can incorporate in the quiz. Then there is another question that I don't know if you like to try to answer. In which cases would you consider to perform a nail ultrasound or a magnetic resonance? So which are the conditions that the imaging techniques will help us a lot? So one is was shown by Nisa, is glomus tumor that is very well seen in imaging technique. Another one I can show you if you like, very typical from a radiologic point of view is this one. This one. Where is it? No, I cannot show you. Sorry. It's keratoacanthoma. Keratoacanthoma is an entity that is typified by a small, usually circular loss of the nail plate. It's also painful frequently, like glomus tumor is, and it has very typical radiologic findings. So exostosis, of course, is also shown very well by an X-ray. I don't know what else.
I think that's it.
That's it.
Wonderful.
Great. Kostas.
At your orders, sir. Allora.
Allora.
Nails. So, 73-year-old patient presents with this
Oh,
presentation. And Sebi, if you can ask the question, what is the underlying condition here? Is this paronychia? Is this a squamous cell carcinoma? Is this a melanoma? Or is this onychomycosis?
I predict that the winning answer will be squamous cell carcinoma. Yes.
yeah, I see.
Really interesting. So, Emilio,
Don't say it's a melanoma.
well, it's a very neglected case of paronychia. As you can see, the actual nail has not been affected at all. It's only in the perionechium. And the patient came to me like 2 days ago. I haven't put the pictures in, but with topical corticosteroids, like along with antibiotics, like a mixed cream, it has subsided completely. Like the nail is completely normal again.
Wow.
So this was
Was he diabetic? Diabetes?
No,
Diabetic?
not diabetic. And that was the interesting thing. This is just the hypertrophy from the paronychia.
okay. So probably she got an infection and now the infection is gone and it's just the hyperkeratosis is remaining. Yeah.
Exactly. But it has subsided with topical steroids and inclusion.
Yeah. We know what is this.
You know what this is? Okay. Sebi, ask the question.
Melanoma, onychomycosis, exogenous pigmentation, pseudomonas. Yeah.
Let's see what people think.
So probably you treated the patient in a few minutes, right?
Well, actually, it wasn't a few minutes because the patient nails were like this.
Ah,
Ah,
wow.
ah,
She was wearing these very tight black leather shoes, and
Yeah.
all of the leather pigmentation has gone to all the nails. As you can see, only 2 nails were spared because anatomically they were more depressed.
Yeah.
Yeah, but it was very interesting. She came in because a neighbor, of course, told her that she has multiple melanomas. And
Well,
she
but you
came
can
back.
then you can recommend to paint with black the 2 remaining fingers.
The remaining 2, yes. I also suggested that, to be honest. It will be homogeneous. Case number 3, a rare disease. And how is the structure depicted, especially this one or this one called?
Yeah, this is
Nice.
white superficial onychomycosis.
Yeah.
onychophytoma.
Yes, exactly.
Onychophytoma, yeah.
It's called onychophytoma, and it's an inclusion of dense trichophyton cultivations.
I think it's called white superficial onychomycosis.
Superficial, white superficial, yeah.
White.
And it's different from proximal, white proximal onychomycosis, right? Yeah.
White superficial is another name, yeah.
Another patient.
In contrast, this is not white.
Yes, this is not white. And this is dermoscopy of some of your nails. And how often did the patient have shellac manicure, like the semi-permanent manicure? Every 2 weeks?
Every 2 weeks.
So the patient was a manicurist herself, and she was doing for the past 6 years, every 2 weeks, a new semi-permanent manicure. And she came to me because her nails were destroyed. And I was like, yeah, they are.
Yes. So what? So what?
So what? I recommend her to stop doing like the treatment. She never came back to me. Didn't like the answer.
Yeah. Interesting.
And now, I really like this case. what is the underlying condition of this dermoscopy image? This is an image of a nail.
Hmm.
Is this melanoma? Is this squamous cell carcinoma? Is this Kaposi sarcoma? Or is it onychomycosis?
Kaposi.
Well, Kaposi, I never saw a Kaposi of the wow, look at this. Yeah.
Wow.
You see? It's so impressive, right?
Yeah.
Yeah.
It has
Oh,
it has included like the
chronic
entire
lymphedema.
yes,
And what,
but
how did you treat her?
Kylix
What?
chemotherapy.
Chemotherapy, yeah.
Yeah.
Immature.
Kylie, it's what's that? Doxorubicin? I don't remember.
Yeah, it's doxorubicin.
Yeah.
But it's so impressive that it has taken over the entire nail plate.
Yeah. And there's a severe lymphedema here.
Yeah.
Maybe due to the lymphatic
Usually-
obstruction.
But was this a sporadic case or there is something underlying here, Kostas?
Sporadic.
Just sporadic.
Yeah. Mediterranean sporadic. Yeah.
Mediterranean, classic Kaposi.
Yeah. Classic Kaposi.
How common is it in Greece,
Very,
Konstantinos and Emilios?
very.
Kaposi.
Like
But-
in our clinic, I think that we have 300 patients in
Yeah.
follow-up.
Many.
Well, we also have a lot of patients. I think Greece, Turkey, Israel, in the Mediterranean part, it's very common.
But I have to say, since we now have many
And the-
years experience with Kaposi, the vast majority of the cases do not end like this one. They have just a few lesions, a very benign course, never systemic involvement. So what you
Very
should
rarely. Yeah.
here for me is extraordinary. It's not something that we see. I mean, I can recall a couple of patients, but very, very, very few.
Out of the 300 patients that we have in follow-up, I think that only 3 have systemic involvement and 1 has passed away. Like super rare.
If we speak about sporadic, if we speak about HIV,
Right.
that's another story. That's another story.
Of course. And now here, well, what do you think? What's your diagnosis?
Melanoma this time.
And what is the expected breast low thickness? Is it 0 to 0.5, 0.6 to 1?
There is nail destruction, so it must be something more thick. Yeah,
More.
2.
1 to 2. 1 to 2.
Yeah, even more than 2.
Debbie is correct. It was 2.5.
2.5.
Excellent. And a final case, because Emilio showed it and I really liked it. This is a 12-year-old girl with this lesion clinically and dermoscopy.
Lichen striatus. There's no option like lichen striatus.
Well, there's something similar.
You understand?
Yeah, let's say
Planus.
Excellent.
lichen planus.
Yeah.
Yeah, it's the best option. Yeah,
Yeah, and it's a very nice representation of what Emilio showed before.
yeah.
Yeah. Very nice cases.
Wonderful.
Beautiful. You see how many
Wonderful.
things we are learning today.
Yeah.
Wonderful.
Really,
Wonderful.
really. In my view, these cases confirm what we said, that it's a tough topic also from a diagnostic point of view, not only from a,
Yes.
especially when there are not, of course, for many of these entities, the clinical aspect helps a lot. For example, in psoriasis, you have psoriasis. In lichen planus, you might have signs of lichen planus. In Kaposi, usually it's not a problem. But when the only signs are there on the nail, then it's really tricky to.
It's a disaster. Yeah.
Wonderful.
Wonderful. For example, I had recently a couple of cases of this acrodermatite continua of allopo, this solitary single-digit psoriasis pustulosa. And it's extremely difficult. I mean, of course, histologically, it's not specific. It's a pain. Yeah. Anyway, bene. What's that? The quotes.
Okay.
If the nail is tricky, remove it quickly. Let us
This is
nail
also
it.
nice.
Yeah.
I
Sheep
was-
nails and dermoscopy. Nailed it today. Okay.
I was preparing to include it in the Kahoot, but now Sebastiano helped me.
Yeah.
So,
No, in my view, it's nicer if Sebastiano is
of course.
launching
Eve also added a very nice one. All hail the nail.
yeah. If the nail is tricky, remove it quickly is the winner. Definitely.
Nice.
Yeah.
If the nail is tricky, remove it quickly.
Yes.
Uh,
Hey, Emilio, do you have to tell us something?
Yes, I do. Yes, I do. Just wondering if we got all the questions. Probably yes. Have you seen a case of median canaliform dystrophy of Heller? No.
A what? Of what?
Median.
No. The medium canaliform dystrophy is very common. Is due to
Okay. This one. This thing. Okay.
this one.
Oh, okay, gotcha.
It's very common. Very common. Usually, it's clinical
Yes.
diagnosis. Dermoscopically, you see not longitudinal but horizontal
Linear, yeah.
parallel lines. Yeah.
Francesca asks how to intervene surgically in case of nail squamous cell carcinoma, bone resection also, or just nail and tumor removal. I would say, we discussed it earlier, similarly to what you do in the skin. I mean, you excise what you think that is involved. It might be that the bone will be involved, but it's a similar approach as you do when squamous cell carcinoma is located on the scalp, for example. So if you think that there is possibility for involvement of the bone, then you have to remove also parts of the bone. If not, not. And I think we got everything.
Mhm.
Show us glomus tumors, we did. Okay, fantastic. Wonderful. So I want to show you a couple of things for the end. The first thing I want to show you, to remind you, is this wonderful armamentarium that Canfield offers, and in particularly to remind about 2D and 3D photography, that using these machines, we have the entire dermatology imaging chain with a clinical photography that can be 2D or 3D, dermoscopy, and we can also add images from advanced techniques like confocal microscopy. And we capture first the clinical images either with the 2D and 3D systems. They have an automatic lesion detection, which is very, very important. And of course, the most impressive thing is the tracking and analysis of changes in sequential images, plus, of course, the help of AI for the evaluation of single photographs with these automated algorithms. And this is the image that we have shown many times, the impressive image of the 3D reconstructed model, and with the automated recognition of lesions and the tracking of the changes. You see how helpful it might be in order to see which lesions changed and to compare also among lesions that changed. Same stuff also with the 2D. The only difference is that you don't have the avatar, but all the other functions are there, the image recognition and also the tracking of changes, which is very important because it means that you have all these functions available, even if you don't have the Vectra, even with the 2D machine, you have all these functions working. Then the next thing I would like to show you is you can guess, I think, what it is.
Yes, we look forward.
Look forward to the gifts that Penelope sent us this time. And we start, as always, with the smiling sweetness. Nisa, 53-year-old, no medical history, old lesion on the scalp, becoming troublesome, non-pigmented, as you can see. That's the dermatoscopic image. And Penelope helps by saying that it's not a BCC. So when it's not a BCC, what should it be?
Everything is possible. Adnexal.
Adnexal. I love Adnexal.
Yeah.
Metastatic melanoma.
Come on, Nisa. No.
Well, but we are at the end of the day. We feel a little bit pessimistic. Yeah.
Nevroma.
Nevroma.
Nevroma. Yeah. Yeah, vascular pattern with telangiectasias, of course. Solitary circumscribed nevroma. Konstantinos, that's for you, 33-year-old, asymptomatic nodule of the face becoming aesthetically embarrassing. Clue, present since childhood. Do you think it is the first case of congenital BCC or is it something else?
Trichorastoma.
Definitely not BCC.
Adnexal.
Adnexal, I would go for. Neuroma.
Another nevroma. Two nevromas. Yeah.
You see.
Thermal nevus-like.
Another neuroma.
Yeah. Another nevroma. For the philosopher, 73-year-old asymptomatic for piggies, solitary scalp, dome-shaped nodule, scalp. That's important.
Male or female?
Male.
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 Cylindroma.
Yes. Wow, very good. Cylindroma.
Yeah.
Cylindroma. Yeah.
Che culo.
Yeah. No, scalp is helps because there's a typical appearance of cylindroma, similar to BCC, of course, similar to spiradenoma. Arborizing vessels and so on. Did I ever tell you that I love cylindroma because the first paper I ever wrote was Dermoscopy of a case of cylindroma.
Really?
Yes, and I described that it looks very much like BCC.
Bravo.
Oh, you discovered, you discovered hot water.
But the vessels are not so well in focus. Because this was the first paper. I mean, come on, it was important back then. Yeah. And for me, 75-year-old past history of numerous non-melanoma skin cancers, solitary firm scalp nodule, recent explosive appearance. I have to tell you guys that my case is the best this week. It's the best, you will see in a moment. So this is non-polarized light. You see that this is a very unspecific pattern with erythema, with some dotted vessels, some white color. I mean, come on, what can you conclude from this?
Hydroadenoma.
But look what happens with polarized. So it's
white lines.
Full of white shiny lines, which theoretically raises the suspicions of malignancy, but it's not malignant. And by the way, this gives me the opportunity to say that with time we discover more and more benign tumors that display white shiny lines or streaks, not rarely. This one was a case of pilomatrachoma. There is somehow a rainbow pattern, Pascal suggests. Well, in fact, there is a little bit of homogeneous red plus homogeneous pink plus homogeneous white. This happens in pilomatrachoma. We know it, that there is sometimes the presence of vascular colors. Anyhow, of course, that's an impossible diagnosis from a clinical point of view. But look how intense white shiny structures it has. So it might happen. Thank you for the great case, Penelope. And for the nicest of coordinators, dear Sebastiano, we have this 38-year-old man, no medical history, scalp nodule since 2 years, becoming troublesome. Against
Idrocystoma. Idrocystoma, like.
Hydrocystoma. Why do you say hydrocystoma?
Because it's translucent.
Translucent.
Yeah.
Translucent. Okay.
It's an adnexal tumor.
Bravo, Sebastiano! Oh. And he did not say adnexal. He did not say adnexal. He said hydrocystoma.
Yes, very specific.
Very specific. By the way, again, some kind of shiny white structures, maybe blotches in this case. Yeah. Wonderful. Thank you so much.
Thank you.
Pascal. And Do you think that it's time for Kahoot? I think so.
I think so. I think so.
Wonderful. Let's do
Sebi,
it.
you have fusarium background. Sebi, you have fusarium background.
A fusarium background, yeah. Yeah.
Okay, let's go. Get ready.
In the
for-
meanwhile that you prepared, Emilio, guys, I have to tell you a nice story about this weekend. We were together with Emilio and Iris in Warsaw for a course. But this was pretty, I mean, we were in a studio and making the records, no public, no audience. And I was supposed to start speaking about vascular lesions. And Iris and Emilio were starting laughing about me speaking about lacunes, and showing so beautiful cases of hemangiomas and cherry-angiomas and so on. I don't know what happened. You know, the story that when you start laughing and you cannot laugh, then you cannot resist. So they were both crying. They were crying with drops, with tears coming out from their eyes, like this.
By the way, I received a very nice photo of that moment that I am embarrassed to show publicly.
Oh, show it.
us.
Show it.
Yeah, show us.
Come on, show it.
Let's
Come on.
Let's
Come
play
on, show it. Come on, show it. Show it.
It was unbelievable. I mean, because as you say, when you get into this mindset, it's impossible to resist. Because once from the moment that Iris said to me, so now Jeppy will speak for 20 minutes about angiomas and lacunas, and she started. That moment, it was no. Yeah. No, I don't show the photograph. Let's play.
Let's go. Let's
go. In my view, we start in 5, 4, 2, 1, and boom. Connection lost. Oh. No, it's back. But I forgot to share the sound, so we will do it without sound, or JP will sing.
I will sing. Don't worry.
Okay, so that's the first case. You see the clinical image. I don't have to say anything. You see what you see. You will see the dermoscopy of 2 of the lesions. Unfortunately, becomes a little bit blurred in Kahoot, while the images are very nice in reality. But still you can see, in my view, the things that you need to see. And let's vote. Do you think that these are 2 basal cell carcinomas, 2 dermatofibromas, 1 and 1, 2 lichenoid keratosis, lesions of lichen planus, or lesions of discoid lupus?
Yes.
Do you have your answers?
Yes.
Yes.
Very good.
Oh, discoid lupus.
Discoid lupus. Not so easy, I would say.
No.
So it's the end stage, of course, of discoid lupus, in which there is pigment incontinence. That's why we see dermatoscopically great brown color, but there are still some follicular plaques remaining in the central part. So that's a case of a very nice case of discoid lupus. And we have Chi, Taha, and blue cocktail in the 3rd place. Second. You like it?
I like it.
This image, strangely enough, did not lose the quality. I don't know why this happens. Also, the dermoscopy is nice.
Beautiful. Yeah.
Very nice.
Yeah. That's dermoscopy. And let's vote. Do you think that this is a case of dermatitis, psoriasis, lichen planus, or rosea?
Beautiful. From a clinical point of view, it doesn't look like a rosea.
Yeah.
Exactly.
Clinical point of view, I thought that it's psoriasis or syphilis, something like that.
I thought syphilis. Rodanthe.
Yeah.
But
Yeah. The
Wow.
scales are very characteristic. Yeah.
Wow. Yes.
That we have dermatoscopes.
Yes.
Yes.
So Chi, Ali 3M, and Bellis B are the three first in the classification, which brings us to case number
Oh,
3. So case number 3, you see that there are again multiple lesions, 2 located on the cheek, 2 more located on the chin, erythematous scaly somehow. Okay, that's dermoscopy.
Mhm.
Dermatoscopy is great.
Mhm.
Yeah.
Do you have your thoughts? Don't say, but do you have your thoughts? What it could be?
Yeah.
Yes.
That's a unique case, guys, by the way, you will see.
Beautiful.
So, do you
Okay.
think it's rosacea, dermatitis, lupus, lichen planus, folliculitis, or sarcoidosis?
Piri biri bip 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 piri bip piri biri bip bip pap 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 para 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 pap pap para para pap 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 pip pip pim piri pip 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 piri biri pip piri biri pip 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 pim.
Let's say that clinically I thought something else, and dermoscopy changes the.
The scenario.
Oh,
Yeah.
so
Yeah.
look, we
No,
have
no.
2 correct
Both?
answers.
Both. Yeah.
Those that voted discoid and those that voted lichen planus, they are both correct because this is the so-called lichen discoid lupus lichen planus overlap. This is a described entity, and in fact, the one lesion was typical of lichen planus, the one with the Wickham's striae, the obvious Wickham's striae. The other one was much in favor of discoid lupus. By the way, there were also some findings in the systemic examinations for discoid lupus. So this is the so-called lupus lichen overlap, which probably you do remember from your residency or not. I don't know. I could hardly recall that it exists, but then I checked and it exists.
Lupus planus.
Huh?
Lupus planus.
Lupus planus, exactly.
The typical, the classical lupus planus. Yeah, we know everybody. Yeah, yeah. Everybody knows it. Yeah.
I forget. I've never seen it, by the way.
What were you thinking?
I just know Rowell syndrome, which is an overlap of lupus and erythema multiforme, but I've never heard about it. This overlap. Great
Yeah.
case.
But what were you thinking? You were thinking lupus.
Lupus.
I was thinking sarcoidosis on the clinical.
I was thinking about lichen planus.
Yeah, lichen, dermatoscopically, lichen is more likely than lupus. But anyhow, but of course, there are some follicular plaques. So in the end, it was this overlap. Very good. So let's see what happens. Chi remains there. Chin and
Unbeatable.
Yeah, Chi is unbeatable today. Yes.
Yeah.
Which brings us to case number 4. You see, today is an eruption day.
Okay.
Want to see more? No. It's okay for you?
Okay.
Let's see dermoscopy. Good. Okay. Ready to go? Let's go. Diagnosis. Do you think that this is lupus, mycosis fungoides, dermatitis, granulomalulare, psoriasis, or scabies?
From what you wrote here, it could be a couple of things, at least.
Which is your preferred one? Say quickly.
I will go
Granulomulare.
with mycosis.
Mycosis fungoides.
Yeah.
Mycosis fungoides. Yeah.
I'll go with the myth because it has the less specific criteria.
Yeah.
Less specific, but this is what we repeatedly see in
Exactly.
not many things, but then there are some vessels. They are small, they are linear, they are these tiny things. So it was a case of mycosis fungoides, and by the way, the majority.
Our audience, let me tell you, is super expert. Is impressive.
Exactly. Luigi is in the first place now. Blue cocktail and Chin follow. And we have one more case to go, which is this one. Again, unique. Unbelievable. So that's the clinical, that's dermoscopy.
I know what it is.
Are these glomerular
Know
vessels?
what it is?
I know what it is.
How do you know what it is?
Your preferred tumor.
You cannot imagine. Well, if you stick on dermoscopy, you might imagine, but the location is so strange that you will never believe it.
But because
Let's
it's
see.
blurry, Emilius, were those glomerular vessels?
No. No, they're not vessels. It's not blurry. I mean, they are
Now, don't tell me that this is a molluscum.
plantar
Yeah.
wart, callus, molluscum contagiosum, squamous cell carcinoma, melanoma, or ecrine poroma.
I would have said poroma, but
Poroma,
now that you put it
But
there,
there were
it's
two. There
molluscum.
were two.
So, in molluscum.
Molluscum contagiosum.
Well,
How can it be possible?
did you take a biopsy?
Yes, by the way. Yes. Yes.
Did you
By
ask, you ask for
molluscum.
You should publish this, Emilios. I have never seen on the acral region.
From a dermatoscopic point of view, it makes sense because there
Yeah,
are.
but did you ask a little bit of history? No. You don't care about history. Anyway,
Okay, podium for today.
podium.
Case for today to Blue Cocktail.
Bravo.
Second place to Stella.
Stella.
And Stella, I can imagine who is Stella. Luigi is the
Ah.
winner.
Oh, Luigi.
Luis was coming suddenly in the game.
Yes.
Ah.
Luigi. So let's see if we can see who is Luigi.
Luigi.
Mariana Arvai.
There is a high likelihood that he's going to be from Italy.
It's Mariana Arvai.
She said that she doesn't have camera.
Camera. Okay.
From Buda.
Congratulations.
Bravissima.
Yes.
Bravissima.
It's very challenging. Bravo. Well deserved championship.
Wonderful episode, guys. Do you love me?
More than ever.
You know that I love you so much.
More than ever.
Va bene. Ciao
By the
Seppi.
way,
Ciao, ciao.
Hi, hello.
Fusarium
Hey,
Seppi.
Mariana, welcome.
there was a proposal in the chat that we should do recurrent lesions, recurrent melanoma versus recurrent nevus, recurrent things in general.
Very good topic.
Yeah.
And the other option was white
I
collar.
have it. Let me tell you, I have it in my list. So let's do it. Yeah.
Okay.
Okay.
Pitzni Vai also is a suggestion. Wonderful. Fantastic. Guys, have a nice week. We love you all.
Marianne is with us.
Bye.
She's so
Hello.
Yeah.
Marian is with us.
Mariana.
Hello. Hello, good
Yeah.
evening, everyone.
Congratulations.
On a very challenging Kahoot today.
Yes. Lucy is not my name, it's my daughter's name, who is here with me.
Congratulations.
Congratulations.
Thank
Very
you.
good. Very good.
Congratulations,
Thank you.
Marian.
Brings good luck
Very
to you.
well done.
Thank you. Thank you very much. Have a nice evening.
Likewise.
Bye. And have a nice week.
You too.
Bye.
Bye.
Jingle, Sebby, jingle.